absolutely excited to be this year's flagship event for the Heart Valve Disease Awareness Day. While we would love to have done this in person, we're glad to be able to do this discussion to all of you online. We're all in separate rooms, Peter, myself, Joan, Amy, so we're maskless. However, we are in separate, we're more than 6 feet apart. We're in different rooms by multiple walls, so we feel pretty good about that. We're glad to really be able to bring this discussion to all of you kind of online. We are proud partners of the Valve Disease Day and understand how critical it is to raise awareness about this disease, which is why we've been sharing messages of this campaign through all of the media outlets and all the social media different venues also. So we're really excited about this. And just a lot of credit goes really to Lindsay and others who have really been instrumental in really bringing this to attention, the idea of Valve Disease Day. So we're just honored to be this year's flagship event here at Piedmont Heart Institute in Atlanta, Georgia. Amy, I guess John's not on yet, is that right?
No, he is logging on as we speak, but I'm not sure. Maybe we just pivot a little bit and have
Yep.
Joan go first.
Well, I think it's a unique day today because it's 2/22/22, and I know in NPR this morning there were a lot of people talking about the significance of that day, and I was just thinking how important it just to have Valve Disease Day on such a kind of a day that will never come again in our lifetime of 2/22/22. So think about that as you go forward. We are going to pivot a little bit to a very good friend of mine and Amy's, and someone that we have. She's actually my boss in some ways. Um, she's my boss in the sense of the TBT world, of which I'm the co-chair with John Carroll, who's the chair of that. And Joan has been with the ACC for over 12 years now. She is the director of the Sts Acc Tbt Registry. And that registry houses all of the TAVR and mitral clip cases done in the United States. It's absolutely unbelievable. She's a registered nurse with extensive experience working in the cardiovascular area. She's had several cardiac management positions at the Inova Heart Institute in Fairfax Hospital in Falls Church, Virginia. She's prior to coming to the ACC, she was a director of the NIH Cath Lab at Suburban Hospital in Bethesda, Maryland. And she's received her BSN from the University of Pennsylvania in Philadelphia, and also her MSN from the Catholic University of America in Washington, D.C. So it's my pleasure not just to have Joan here in her role professionally, but just really a close friend who has done more for valve disease in the United States than a lot of people. Even she's a behind the scenes person, so we don't even know it. So Joan, we're just really honored for you to join us today.
Thank you, Dr. Thourani. Wow, that was a very nice introduction, and I am thrilled to be here. I pulled out my red Heart Day outfit, and again, I'm very honored to be here. We have a lot to celebrate with the Sts Tbt Registry, and I'll go through some data and the milestones that we've reached. But the points that I want to really stick home with is it is our 10th anniversary of the Sts Acc Tbt Registry. So it seems like it's been a minute ago, but 10 years is a lot to celebrate. And this month, actually, we just launched public reporting. So that sort of toggles the line between what's important for hospitals and what's even more important for patients in our community. So now that, we had a lot of patient advocates through the years saying, when will you be able to publicly report this data? And everyone in the field knew we needed the sweet spot amount of data in order to do that. Well, we have that now. And right now, as we speak, and if anybody after this call would like to contact me and say, where do I look for this? I never heard of this. I'm happy to show you the two sites. And I will show you the two sites in my slide presentation where you can go for more information. So lots to celebrate with the registry. What I thought I would do is go through a couple of data slides, and then maybe that would tweak some points of conversation or questions that you might have. But again, I am honored and thrilled to be coming to you live from my basement in DC. Happy we are back in the office, but not every day yet. So life is getting back to normal. It's a very cool feeling. Let me see if I could share my screen. And again, just a few, I pointed out a few of the TAVR slides. The TBT registry actually has 4 modules, both in the aortic space, mitral repair and replacement. And we just in our new version upgrade added tricuspid. For those practitioners out there, you realize tricuspid is still off label, but we had a very wonderful experience doing some data collection on off-label procedures before, and FDA took a look at the data, the registry data actually, and that's what allowed them to move forward. I believe it was in 2015 to approve a device to be used in the mitral space. So that's why we want to start collecting tricuspid cases now, even though they are off-label and things will change shortly. So here we go. Again, you're happy to receive these slides, and this is just a sort of a tip of the iceberg of some of the data we collect. So right now, the registry has a little, we're right in our renewal season, so we're closely approaching 800 sites, but 778, 780 sites are actually actively participating. All in the United States. There is a TAVR program, at least one, and only one in Wyoming, but at least one program in each state in the contiguous United States. And we also have Alaska and Hawaii represented. And there are 3 programs in Puerto Rico, all collecting TAVR data. When you split that out to the mitral side of the business, there are about 480 sites. Usually a hospital starts with TAVR and then picks up mitral. So again, close to 780, pushing up 800 sites for TBT in the TAVR space, and about 400 and close to 490-ish in the mitral space. We like to collect both TAVR cases and also the valve-in-valve cases. And Dr. Thourani could remember us saying, well, we never see valve-in-valve. And we're like, well, we don't know. As soon as we said that, you can see in 2015, those started it up. So now we collect both straight TAVR and valve-in-valve. And I included when intermediate risk was approved and then when low risk was approved. And you could kind of see the bump up in cases. And again, the red bar shows the valve-in-valve procedures. Median age, this is an interesting topic, especially with low risk. The median age has hovered at 82 forever. And now with low risk, you could see that comes down to 75, but with intermediate and high risk, it's still in the 80, 81, 82 range. Where this will go, it's anybody's guess. But again, with low risk, we have seen younger patients. This is a kind of a pause, aha moment, getting a lot of attention with health equity, disparity in care, access to care, lots of conversation going on in this arena. And this is a powerful yet maybe somewhat disappointing slide, because you can see we really haven't made any headway from 94% to 92% white, but that 4% staggering static of Black population is acceptable for a lot of reasons. Now, pausing and looking at this slide, you probably know or should be aware that this breakdown is really no different than the SAVR population. However, you could take this for orthopedics or any other subspecialty and say, well, there is a problem of disparity, health equity, access to care in all subspecialties. But here's where I say and challenge you all that this is different. This is different because AS, I guess, has a runway or possibly a year to a year and a half after diagnosis, or the patient does not survive. So that makes it different. And it also makes it different because, again, the age of the patient that we're seeing, even in the low risk being at 75, that is well within the Medicare age of treatment. So there should not be so much of a cost barrier. So there's 2 points to remember when you look at this slide. We have to fix this. What degree is anybody's open for anybody's suggestion. Basically, since aortic stenosis will kill a patient in a year to a year and a half if not treated, it should be covered. So finances should not be the be-all end-all reason for not getting care. This lots again discussion about health equity, and I hope this slide will allow you to go back to your hospital, to your community, and say, how are we doing locally? Because now you know what the national data looks like. We looked at this a little bit further and plotted out all minorities are lower than perhaps they should be. You could take this to every subspecialty group. But if you look at just the Black population plotted out where the red dots are the TAVR sites, there's one slide, and here's another slide. You really can't get much out of this information other than it doesn't seem to be an access issue. Early on with TAVR, we thought there was an access to care issue, and that's why African American Black patients were not getting cared for as much as white patients. That does not seem to be the issue now again. So if nothing else, these 3 slides should make you pause and go back and look at your own local hospital and areas of care to say what can be done, what should be done, kind of a look under the roof moment, if you will. Location, this is a very important question. I like to highlight this during COVID because capital resources for hospitals is becoming very finite, very scrutinized. And so if someone is going in for capital allocation and saying, we need another hybrid OR, we need another hybrid cath lab, there might be more questions being asked now with financial constraints, dealing with a lot of hospitals have to spend resources on PHE, whereas before they would have access to funding for building out and adding capital requirements. So you want to see where are these cases being done. And there, obviously, a lot of them started out in the hybrid OR. We have a lot of pictures in the early days of standing room only, very much like in your hospital when you perhaps witnessed the first lung transplant or the first heart transplant. Well, the first TAVR was standing room, the echo machine, the ECMO, echo, 3 anesthesiologists and everything. That has sort of settled down now to the point where many of these cases are being done in a regular cath lab. So that's a nice slide to show if you're looking at resource allocation. Femoral access. There was back in 2016, I think there was a spike up in transapical access, but for the most part, we're at a 96% rate of femoral. So most cases are now femoral access. Why would we want to look at femoral access in that we're now within the registry, sidebar on what we could do with data. We could look at access, issues with access, and perhaps even taking that onion a little bit deeper and peeling through to say, is there an opportunity to do a focused clinical trial within the registry looking at what access for whatever, for pacing, for sheath access, what's the best place and study that. So a lot of data comes out of the registry for what we have plotted along and collected over the past 10 years. Reasons for the procedure. At the beginning, the game was, extremely high risk. That has ratcheted down to intermediate and low risk. And you could kind of see where we're ending up there in 2020, my latest set of slides, where we'll be updating these shortly to include all of last year. But you can see now with all 3 indications for care, what the percentages of we're seeing in the registry. Again, this is an interesting slide, no surprise, but back in the day, if you've been in this game long enough, you can see we started out 5, 6, 7 days length of stay, and pretty much everyone's in the onesie twosie area. During COVID, there have been some programs that even have managed to do same-day discharge with their patients. That takes a sophisticated program, that takes a well-run program, and that takes a program that has a lot of cases under their belt to decide how and when to do that, and patient selection is always important. Very important with pacemaker rate. Everyone wants to know what the pacemaker rate has been both in hospital and at 30 days. And there's a fine line between was the patient indicated to have a pacemaker prior to the case or at 30 days. Stroke rate, we collect this. I would say that no surprise, but the two biggest questions are: what is your pacemaker rate? What is your stroke rate? And you can see both that inpatient 30 days and 1 year, the stroke rate has come down a little bit. And since we started collecting the use of cerebral protection in January of 2018, we're also tracking what has that done, if anything, to the stroke rate for the TAVR patient. And again, these are, obviously mortality is a big complication that we do track, and we've tracked that for the low risk. Both blue is inpatient 30 days, and then this is our 1 year stroke mortality tracking. This is for intermediate risk, and then the low risk patient as well. And you can see where the mortality rate is for the low risk patient. I'm sorry, for the high risk patient. Sorry. Another, especially during these past 2 years, where are the patients going home, or where are they going? Are they going back to their home? Or are they needing a higher level of care after TAVR? And we always like to show this, that 94% of our patients go back to the place where they came from, so back to their home, which is really positive. And again, that matching with the length of stay being pretty much 1 to 2 days, that's a real success story from where we began 10 years ago. Now that we have all this data, and I think Amy mentioned greater than 200,000 cases, both in the TAVR space. Now, what could we do with this data? And the number of cases we have now have allowed us to do public reporting. And how did we come up with the public reporting metric, risk model, method of measuring? What is a gold standard program? What should you try to attain to be? The two metrics that we decided to publicly report on a voluntary basis with the volume of all access, but only commercial cases, so all access, but again, remember 94% are femoral access. And then a really sophisticated 30-day mortality, morbidity composite risk model was developed. We initially said, let's look at discharge, but the 30-day composite risk model is really kind of the gold standard. It really encompasses a lot of evidence-based, looking at all of the data. What did we look at? They looked at nearly variables. I think what came out to be 46 variables, and you could see all the variables that are encompassed in looking and developing the risk model. I point out gait speed and my very favorite AACC as two of the check the box in order to get to the dance, because you have to have your 5-meter pre-procedural 5-meter walk done, and you have to have your baseline KCCQ done at a 90% or greater completion rate for a rolling 3 years in order to be able to be eligible for public reporting. So remember that KCCQ, the quality of life indicator that was used for pre-market trial studies, we've continued to use that with the Sts Acc Tbt Registry. And it reminds me, this is a multi-stakeholder driven registry, not only with our physicians from ACC and STS, but also our industry partners at FDA and CMS. And CMS is very clear about agreeing to pay for these very expensive cases. And that is this: if you can prove to me that the patient's quality of life has been improved, we are willing to support this program. And that is why the KCCQ is so critically important. What is that patient's quality of life? Do they feel better? At the median age of 82, they may not live 20 years, but will they live the next 5 to 10 to 15 years with a better quality of life? And that's what we're here to prove, and we've done so successfully. Back to the composite risk model, and a lot of people have questions about what is looked at. And we say it was done in a hierarchical model, so none of the above, the patient had no negative outcomes, or in a hierarchical model up to the point of they had an in-hospital or 30-day death. and we'll only ever count the highest one that was reached. So if the patient had a stroke and also died, you're only counted for the mortality. But I want to point out on this why, and I know Peter's on the call, so I hope he appreciates this. PVL in hospital or 30 days is a key data point that we look at when determining the risk model. So again, during COVID, it's been very difficult with staffing, with resources, with scheduling, with having the patient come back for their echo. We will accept either the discharge echo or the 30-day echo. Certainly, we would prefer the 30-day echo, and we will look for that first. But if there is no 30-day echo, we'll look for the pre-discharge echo, determining that element for the composite model and looking at PVL, and I hope that helps. So this is just showing you where you could find your public reporting rating for any hospital. If you go onto the STS website under TBT Registry, and then just write in any hospital name there, what'll pop up is what the public reporting star rating, either 1, 2, or 3, looks like for that hospital, and then what was their breakdown. So you could see that on the STS website. You could also see that on the ACC CardioSmart website. So we work hand in hand to be able to push this information out so our community will know exactly what is the result of all the work that your hospitals have been doing. And I point out, if you want to get into a little bit of a deeper methodology on how that risk model was developed, the publication, the manuscript is found in Circulation. Again, I have a copy of it. If you'd like to contact me, I'm happy to send any of this information to you so you could be more well informed on what we've been doing with all the data we've collected. A word about U.S. News and World Report. When U.S. News and World Report 2 years ago started announcing in part of their cardiology best hospital, they also have best TAVR. Not that they'll give 1, 2, or 3 stars, but they'll denote the best TAVR program. And just a word that their methodology is done differently. We're using registry data, whereas CMS data is used for U.S. News and World Report. They use claims data like they do years and years about all subspecialties that they report out on. They'll use claims data, whereas we're using registry data. However, some of the endpoints obviously are the same. So this is just sort of an awareness of we are both presenting data, but a little differently, data sources. I'll stop there and see if you have any questions. I hope that was a little bit of an interesting enticement to ask for more information. And again, I have the information for the mitral and soon the tricuspid modules as well. We're very excited to be able to show that soon.
Yeah, Joan, that's absolutely wonderful. There's no one better to be able to present the country's data and so eloquently done in about 15 minutes. So it's absolutely great. Thank you so much, and look forward to some discussion with you soon. Before, Joan, we get to that, Dr. John Whyte will be our next speaker before we get into a panel session. He's a very popular physician writer who has been communicating to the public about health issues for nearly 2 decades. Dr. Whyte is CMO at WebMD, and in this role, he leads efforts to develop and expand strategic partnerships that create meaningful change around important and timely public health issues. Prior to WebMD, he served as a Director of Professional Affairs and Stakeholder Engagement at the Center of Drug Evaluation and Research at the FDA. And prior to the FDA, he worked nearly 2 decades as a Chief Medical Expert and Vice President at Discovery Channel. Dr. Whyte is an internist who continues to see patients in Washington, D.C. and Maryland. I'm sorry that when I was in D.C. at MedStar, John, we didn't get a chance to meet, but at least we're meeting virtually now.
I hope you can hear me okay.
Perfect. We can hear you great.
So it's a great lesson here. I work at a multimedia company and I had a lot of challenges logging in today, but I'm glad able to connect. And I want to thank you because it's my pleasure to really engage in today's panel discussion on heart valve disease with you and your colleagues at Piedmont Healthcare and the Marcus Heart Valve Center, as well as with Joan Michaels, American Heart Cardiology. And as I mentioned, my colleagues at WebMD, Medscape Education, and MD Edge all wish you and everyone participating in a happy Heart Valve Disease Awareness Day. As you mentioned, I'm a practicing internist, I'm a health communicator. I always find it fascinating when the media covers when things come to our hearts, because most Americans have heard of heart attacks, coronary artery disease, even AFib, our watches are detecting that. But they're really left with a troubling blind spot when it comes to other types of heart disease, including heart valve disease. And that's why I think it's so important to have these conversations, because it's especially concerning that most deaths from heart disease, including heart valve disease, are preventable if people recognize the risk factors and symptoms and get timely treatment. But the reason why we're all here today to raise awareness is a lot of people have never heard of heart valve disease, even though it impacts, as you all know, more than 11 million people just in the United States. And a survey from my friends and colleagues from the Alliance for Aging Research found that more than 2/3 of respondents said they know little to nothing about heart valve disease prior to the diagnosis. Nothing. The survey also revealed that 6 in 10 respondents who were diagnosed with heart valve disease either didn't have symptoms or they more likely didn't recognize their symptoms. They attributed it to something else. And that's because, as you know, the symptoms of valve disease may not be obvious, even if it's a severe case. So we're fortunate to have people with a wide range of medical knowledge tuning in today. But if you've never heard about it, heart valve disease occurs, as you know, when one or more of the heart valves is damaged. And we saw a nice description of that. And that interrupts blood flow and causes serious complications. And people need to know the potential symptoms of valve disease. And we talk about mnemonics. We all like mnemonics. And the one that we talk about is listen to your heart, which is the theme of Heart Valve Disease Awareness Day. So what does it mean? L stands for lightheadedness, faintness, fainting, dizzy feelings. I is irregular heartbeat. It could be a flutter or chest pains. The S is for shortness of breath after light activity or even while lying down. T is tiredness, even after plenty of sleep. We all feel that way, but usually not after plenty of sleep. The E is for edema, which is swelling of the ankles and feet. And N is not feeling like oneself and missing out on daily activities. And I apologize for the lack of slides. I was just happy to get on right now. Next time. But the point is, if you or loved ones, folks that are listening, are experiencing these symptoms or having the risk factors that I'll mention in a minute, the key is to not ignore them, to speak to your doctor, to ask about a heart exam. I often fill in for other doctors here in the Maryland, D.C., Virginia area, and I always listen to people's hearts. And sometimes they say to me, oh, my doctor hasn't, examined me or listened to my chest in a long time. And that's a little bit of a concern because these can come up later in time. As you know, if you had a heart exam a couple of years ago, it doesn't mean that you don't have an issue now. But fortunately, going to the doctor soon after noticing symptoms, that's when it can prevent a serious and potentially deadly outcome. Because heart valve disease can typically be treated successfully, as we heard, in patients of all ages. And an easily detectable heart murmur can be the most telling sign. That's why regular heart exams could save lives. And we need to focus more on that as practitioners as well as patients. Getting the public to be aware of heart valve disease and to watch out for symptoms is half the battle. In addition to the low public awareness, even fewer people know the risk factors. Probably heard about serious conditions like diabetes, obesity, high blood pressure, put you at a greater risk of severe illness if you get COVID. But, may not know these same conditions increase your risk for heart valve disease. Other risk factors include older age, typically in our 70s, congenital heart defects, bacterial infections, certain radiation and chemotherapy treatments of cancer, and other cardiovascular conditions. In general, those people age 75 and older are at greater risk for valve disease. However, this is not everyone's experience. Black American adults experience risk factors for heart valve disease at earlier ages than whites. For example, the prevalence of high blood pressure in Black Americans is among the highest in the world. More than 40% of non-Hispanic Black men and women have high blood pressure. Chronic high blood pressure increases the likelihood of heart failure which is a primary risk factor for valve disease. And Black Americans develop heart failure before the age of 50 at 20 times the rate of white Americans. While we know that Black Americans tend to be younger when they do develop heart valve disease risk factors, less is known about whether healthcare providers are detecting and treating heart valve disease in these patients. And a recent study found that the odds of being referred to a cardiothoracic surgeon for treatment of valve disease were 54% lower in Black American patients when compared with whites. The National Heart, Lung, and Blood Institute convened a working group in 2019 that was focused on patient-centered research in heart valve disease. It outlined key health disparities in diagnosis and care delivery and identified areas where research can help us better understand and eventually address these inequities. I'm thrilled to be here with all of you today. I wish we could have done it all in person, but on behalf of WebMD, Medscape Education, and MDH, I really am pleased to be able to share a few minutes with all of you today, and I look forward to the discussion.
John, thank you so much. That was great. Thank you for also getting on. I know you had some challenges with the WebEx, but it was great to have you on and just kind of go through a summary of what really happens to patients. And what really struck me, what you just said, is when you see a patient sometimes and you put the stethoscope to their chest, that they're like, wow, somebody hasn't done that in a while. My dad was a cardiologist in Mullins, South Carolina, a small town. I remember going to practice with him when I was a child, and at that time they didn't have all the stuff that Peter's going to talk about in a second. They just had a stethoscope, and he was able to diagnose an EKG, and they diagnosed a myriad of diseases just on those two things. And I think we've lost that a little bit. I think we need to get back to basics, which is just talking to patients, listening to them. I think that's very important. Amy's father is also a cardiologist who practices in Atlanta, and Greg is very similar to that. So I think I want to introduce three people first, and then we'll go just dive right into the discussion. One is Amy Simone. Amy Simone and I have now been together professionally for over a decade, and she is the director of the Bernie Marcus Valve Center as a physician assistant by trade, and is absolutely phenomenal. And so she's really the heart and the brains of our organization here in the Valve Center at Piedmont. So Amy, thank you. Peter Fluger is an absolutely dynamic echocardiographer, imager, specialist, and cardiologist who, without him, he is literally our eyes and guides us in almost every aspect of doing stuff preoperatively, postoperatively, and most importantly, intraoperatively. So Peter's really honored to have you here. And then also Pradeep Yadav, who, by the way, is signing in from India. And so he's wouldn't miss this, even if it meant thousands of miles away and a couple of oceans behind us or in between us. Pradeep is there, and so he's probably about to go to sleep. But thank you, Pradeep, for joining us. He is our head. He and Vivek Rajgopal are our two main structuralists who are the hands of our valve center. So Pradeep, thank you for joining us.
Thank you. It's been wonderful so far. It's about 1 o'clock at night, and I could not resist joining.
1 in the morning. 1 in the morning.
1 in the morning.
Yeah.
Right. So a little IT issue, so I may not be able to turn my camera on, but happy to be here.
No, that's perfect. So maybe I want to start off first with Peter. Peter, why is advanced cardiac imaging such an important part of a patient's workup to determine the best treatment and safest treatment options?
Yeah, thanks, Vinod, and thanks for inviting me onto this panel. I did want to highlight what you and John both said, that listening to your patient's heart is really the first step. I mean, we have a lot of advanced imaging techniques, 3D echo, 4D CT, cardiac MRI, that we can all use to evaluate valve disease, but it really starts with listening to your patients. I mean, the patients don't come to see us for their advanced imaging until somebody recognizes a problem, whether that's their internist, their PCP, a family member, or the patient themselves, if they notice symptoms. But as Vino was saying, imaging really is a key part of assessing valve disease and treating valve disease. Initially evaluating the patient intraprocedurally and post-procedurally. So most patients will have some types of symptoms. Their doctor will notice something. They'll come and get an echo to assess the valve disease, assess severity, and most importantly, assess the mechanism of what is going on with that valve. Because folks like Dr. Thourani and Dr. Yadav can fix the valve either surgically or transcatheterly, but you really need to know the mechanism of how that valve is functioning and what's wrong with it. We use cardiac MRI to further assess valve regurgitation if the echo is a bit equivocal or we don't have good images. And then intraprocedurally, I'll join Dr. Thourani and Dr. Yadav doing 3D transesophageal echocardiograms for mitral clips and other transcatheter therapies. And then as Joan mentioned as well, we assess these patients post-operatively and post-procedure with echo, cardiac MRI, and CT, especially if we notice things don't look like they should or patients are having new symptoms. We really want to assess the valves and the procedures that we've done. She mentioned PVL. All these patients get post-operative echoes to assess for complications. And then we monitor these patients after they've undergone some sort of valve treatment or valve repair, especially if they have progressive symptoms, because we want to make sure that the procedures we've done are still working the way we want them to. And so advanced imaging is very important, both for pre-assessment, intraprocedural assessment, post-assessment. But again, I think I'd like to emphasize what John said. We really want to see these patients when their internist, their PCP, their family member, or the patient themselves says, hey, something's not right. I'd like to get someone to take a look at that.
That's great. Thanks, Peter.
I
Yeah,
just
go ahead,
wanted to
John.
make a comment, because a good friend of mine who's on the panel reminded me. Remember when we also didn't really think women had heart disease
Yep.
until much later? So it really requires that reset as well. I want to give credit to Phyllis Greenberger of the Society for Women's Health Research, who is always promoting that we need to address it in women. So I think it goes to all of your points. We need to get it on people's radar screen, because for a long time we told them they didn't really need to worry about it.
Yeah, you're absolutely right. I think the two disparities that I think gender and race disparities, I'm very happy to have seen a major movement in the last, I think, couple of years now. Joan, right from the TBT, this is something that's been a high priority of ours in the steering committee of TBT Registry, to really start figuring out the gender and the racial disparities between those and Caucasians within valve disease. So that's a really big imperative, not only on the surgical societies, but also cardiology societies in our registries. I'm going to switch over a little bit, Amy, and just ask you a question. How important is a multidisciplinary provider assessment for patients with valve disease? When I was in training in the 90s, it was the surgeon saw the patient, they decided what they're going to get, hell or high water, and that was what was going to happen. Joan's closing her eyes and nodding yes, because she remembers that in ANOVA and other places. That was it. How has life changed now, and what should a patient expect in 2022?
Sure. Well, first of all, thank you. Thank you for having me part of this panel. I'm thrilled to be here. It's really special. I don't think the idea of a multidisciplinary approach or group is necessarily new. It's been in existence for a number of years, but the way that it has embedded itself into cardiothoracic surgery and also interventional cardiology, the world of structural heart disease, is just so enlightening. And now it's actually embedded in the guidelines that we all follow throughout the country. So that's a really phenomenal shift. To me, I think it's absolutely critical to have a multidisciplinary group take a look at each patient. We do individualized, personalized care plans. We're looking at each patient for not only technical feasibility. Peter's, that's his forte, and saying, what type of, let's look at the anatomy, let's look at access, so on and so forth. But not just can we, but should we, and what's some things that play into the patient's kind of overall clinical picture. This is very special, and these groups that participate in the multidisciplinary team, they range from nurses to advanced practice providers, valve coordinators, cardiac navigators, physicians, so on and so forth. We're looking at things like social support, family support for patients. We're looking at social determinants of health. We're looking at patient motivation, and also shared decision making, keeping patients' goals of care front of mind at all times while we're determining a treatment plan together. Patients really become part of this care plan. I think it's absolutely just change the way we treat patients and really bringing them into the plan. As you said, it's a far cry from, well, the surgeon says I should do this, I'm going to do this. Really, having conversation and dialogue with the patients. But I think it's been critical. Long-winded answer, but I feel very passionately about the multidisciplinary approach, and I think it's only shown positive outcomes, patient experience. This, I thought what Joan presented was very elegant in terms of the last 10 years. Look how far we've come just for structural heart disease and transcatheter therapy, and the multidisciplinary group was key to that evolution.
That's perfect, Amy. Thank you so much for just discussing in your mind kind of how that runs. Pradeep, I'm going to jump to you now and ask, what does wakeful watching or valve surveillance mean to you? And if patients are given this recommendation, should they be concerned? So one of the things, you weren't here on Clinic Monday, Pradeep. We saw, Vivek and I saw 3 or 4 patients with EFs of 10 to 15%. That's a heart function of 10 to 15%, normal being about 65 to 70, who now had serious valve disease, and we're at a point where maybe there's no point of return for them. So these people, as we track them, have been having their heart function go down over the last 3, 4, 5 years, and now they come to a tipping point to us with very end stage heart failure. So this watchful waiting, tell us about that valve surveillance. Tell us your thoughts and what should the message be for patients on this?
Right, Vinod. So we do have criterias on when to intervene when the valve is severely stenotic or regurgitant and causing symptoms. We have clear criteria to intervene. But when we don't meet those criterias by the guidelines, oftentimes we recommend patients to follow clinically over next few months with repeated echocardiograms. But in that process, sometimes the patients tend to get lost. And to what you're alluding, that irreversible damage to their heart muscle or their other organs happens, and which then makes a straightforward, simple procedure a high-risk procedure. So while on one side, guidelines may recommend clinical follow-up, but on the other hand, it has to be done very carefully and very closely, whether it's like 2 or 3 months of clinical follow-up with repeated imaging. And the issue with valve disease is very slow progression and very subtle symptoms. Sometimes it could be just generalized tiredness and fatigue and not being able to do the stuff that they were able to do in the past. So any subtle signs patients should pick up even when they're in the clinical surveillance period. Any new symptom, contact us again.
I think that's great, Pradeep. Thank you so much. And John, what would be your piece of advice that you would give to doctors? One piece of advice for doctors, and one piece of advice for patients who are facing a valve disease diagnosis.
So, the big issue, as you all referenced to, it is about shared decision making. That typically wasn't the case before. As Amy, you mentioned, people just did what the doctor told them to do. And I think for that, for shared decision making to be successful, as doctors, we need to be good listeners. We're not often that, as we know. Lots of studies that say we interrupt patients and, a minute from them talking, we're just waiting for our turn to talk and we want to do whatever we want. So that's part of it, learning what their goals are, what's important to them in terms of their activities, their life, the quality of life. We often don't think enough about that. and talk about it to patients, especially when people are focused on technical expertise and what can be done as opposed to what a patient might want done. And then I think on the patient side, and I see it even in general practice and internal medicine, patients are becoming much more informed, and I welcome that. We always want them to go to good sites, but I encourage patients to learn about their disease, talk to other people, and I think a lot of the centers are doing well on that and having them talk to other patients that have undergone surgery, as well as those patients that have chosen not to undergo surgery. So I think shared decision making is key. On the provider side, we need to be better listeners, and on the patient side, they need to do a little more homework too, and learning more about the options available to them and how that fits in with their goals.
Yeah, it's quite interesting, John. It's, sometimes we get patients, and commonly Pradeep and myself, or the surgeon and cardiologist, are commonly in the room at the same time discussing a patient's treatment strategy. So we actually don't even do it where they're separate offices. We actually do it at the same time in the same day, in the same physical location. And a lot of times patients have said to us, wow, I didn't have to wait 3 weeks, and I forgot what the surgeon said to me. Now I'm having to hear from the cardiologist back and forth. So we found that having that together at the same time between the physician, the surgeon, and the cardiologist has helped us make it somewhat seamless, and maybe decrease some of the confusion that two different specialties can give to patients. And I think that's become a problem. And one of the things I want to add to what Pradeep said is that symptoms are very variable. And so commonly you have to elicit symptoms from patients. Even though they're asymptomatic, they're really not asymptomatic. They start, yesterday, I know when I saw some patients, they said, well, I don't get short of breath. I don't get short of breath. And the wife said, but you don't go walking anymore. So, your lack of activity is actually the same as shortness of breath, because if they did the same level of activity, their shortness of breath would actually come about. So it's quite interesting to hear a husband say he doesn't get short of breath, and his wife quickly corrected him and said, well, you stopped walking and that's why you don't get short of breath. So I think eliciting symptoms, Pradeep, I think are important, especially in these patients that have severe valvular disease that are continuing under a surveillance. So
absolutely. More often, we see patients who actually present late, who waited, and now their ventricles burnt, or they have other end organ dysfunction. We are happy to see patients sooner in the disease process, and if they're not ready for the procedure or intervention, we'll follow very closely.
Yep, absolutely, 100% right. Joan, I want to pivot to you a little bit. John used some buzzwords that I think are important, and just want to highlight that and see what your thoughts are. Shared decision making. How important is that to the ACC, to the TBT registry, the patients undergoing TAVR? Just your thoughts a little bit about shared decision making. You and I have had some conversations about this on the steering committee of TBT, but just your thoughts a little bit about shared decision making. How do we incorporate that to be within the registries, that we're actually starting to figure out how to change the bar a little bit to make it more common practice?
You all are music to my ears talking about this. And I want to just give a quick shout out to you, Vinod, and John Carroll, being the co-chairs of our steering committee. This topic came up about under 2 years ago. Shared decision-making is not a mandate, a requirement in the coverage decision. However, both Dr. Thourani and Dr. Carroll brought it to the physician leadership to say, but it's the right thing to do. Start that conversation. So we added that in the registry. And if you think about, short of 800 sites, all trying to sing off the same sheet of music, and within that music is shared decision-making, that starts a national conversation, and it has. Initially, the confusion with some sites are, well, we do that, and then to take that back to say, that's informed consent, and that's different. Shared decision-making is a conversation that a very simple conversation that we just ask that the provider, the physician, the heart team has with the patient, starting out with, why are you here? Did your family member drag you into the office? Did you see this announcement on a subway stop? What do you think you'll get out of this? And that's an opportunity to say, is that expectation real or not? Is it a realistic, or do they think they're, what's their goal? Is it to climb Mount Everest, or is it to get back to daily activities? So shared decision making, I think, is one of the most important elements that we've added to the registry, again, for the purposes of starting the conversation, documenting it. Why? Let me show you the risk and benefits of all your options, right? That's the physician to give that information. And then for the patient to say, well, do you understand that? I understand it. I don't understand it. This is what I want to get out of it. And I've heard many physicians who perhaps were not so keen on having yet another job to do, if you will, and speaking with patients. And they've come around to say it actually has made their job very easy. Everyone leaves the room in agreement because I know what as a physician, I know what I could offer the patient, and the patient then understands what are all the options offered to them and what is it that they're willing to do and the commitment and the expected outcome. So I mean this from the bottom of my heart. I think shared decision making is the best thing we ever did for the TBT registry and #Tavernation, so that patients and families and physicians are all leaving the room on the same page. Thanks for asking that,
That's great. That's great, Joan. Thank you. Peter, I'm going to pivot to you for a second and just ask you, just let our listeners know a little bit about what are some key technologies that are aiding to provide optimal patient care. Is it 3D printing, virtual remodeling, AI, echo surveillance, predictive modeling? What's going to be happening in the future to help physicians and patients with newer technology in order to, is it going to be stethoscope that can diagnose aortic stenosis so that, John, if we've lost the art of listening, or an EKG that can say, boom, you have AS, or a stethoscope that doesn't make you listen to the sounds in S1, S2, none of that. It just tells you you're going to have aortic stenosis. It just comes up on your iWatch right at that same time. What's coming down the pike, Peter, for patients and their physicians?
Really, it's all the above. I think one of the exciting things about imaging and specifically valve disease is the new technologies and different modalities that we have to help patients and choose what is right for each patient. We talk about general categories of valve disease like aortic stenosis, aortic regurgitation, mitral regurgitation, but each patient is a little bit different in their anatomy and their physiology. And you and Dr. Yadav can speak more about this as well, but we have so many treatment options for mitral regurgitation, and coming down the line, tricuspid regurgitation. From an imaging standpoint, we're using CT to model these valves and put different research valves and different types of valves within a 3D model of the patient's heart to say, is this an option for them? Is this a treatment option for them? Here at Piedmont, we've partnered with a company at Georgia Tech to help model some of these valves within a 3D model of the actual patient's heart. How is this valve going to sit? Where is it going to sit? What issues might arise if we put this type of valve in versus a different type of valve? And it really helps to individualize the patient care and the treatment of their valve disease. So each person is not the same despite having the diagnosis of aortic regurgitation or aortic stenosis or mitral regurgitation. So, I think down the line, the 3D printing, 3D modeling, individualizing how we treat each patient based on their actual anatomy, their actual physiology. For TAVR, how are we going to access? Are we going to go transfemoral, transcaval, transcarotid? Each patient is different, and we're using imaging with CT and MRI and echo and 3D modeling to really say what's the safest and most effective way to treat this patient's disease. So I think more automation, more 3D modeling, and more individualization in treatment is going to be coming down the line. It's here already, and it's going to be coming down the line even further for imaging and valve disease.
That's great, Peter. Thank you. And we have about 6 minutes left, so I just wanted to ask a couple more questions. Pradeep, this is for you. transcatheter valve repair and replacement, for instance, in TAVR or MitraClip or TEER, are less invasive with faster recovery. How do the results compare to surgery? Of course, open heart surgery. How do the results compare with traditional cardiac surgery in terms of outcomes and durabilities? I'm fortunate to be able to enjoy doing minimally invasive valve surgery, regular open sternotomy cardiac surgery, and also the transcatheter options. But from a cardiology point of view, how do you think that this compares, these newer technologies, transcatheter technologies, compare with traditional surgery for outcomes and durability? Pradeep?
So we know you've led this field back from early 2000. You've been on the forefront and taught us all this transcatheter technique in addition to surgery. So the answer to your question depends on the type of valve lesion you're discussing. For example, aortic stenosis, right? TAVR has evolved so well these days that the results of TAVR are almost as good as surgery. Durability, obviously, time will tell, but so far we have not seen any signs of premature failure. We think that the TAVR valves will last as long as the surgical bioprosthesis. In a carefully selected anatomy, I think it is safe to say that TAVR is just as good as surgery. And maybe with faster mobility, faster rehabilitation, it's a very attractive option. Less stroke. Surgery wins definitely for PVL in surgical valves. We don't see paravalvular lesions. When you talk about mitral regurgitation, the two different types of MR, degenerative MR and functional MR. For degenerative MR, where it's where the leaflet or the valve itself is an issue, surgery still remains to be gold standard for vast majority of people. And TEER or the MitraClip is primarily for patients who are at high risk or prohibitive risk for surgery. Functional MR, on the other hand, is a little more challenging because there is little mixed data with surgery. It's still a class 2A indication, surgery for functional MR. And for those patients, transcatheter, I think, has an edge. COAPT trial was very, very powerful trial. Number needed to treat to save one life in COAPT trial was 6. So MitraClip turned out to be very, very powerful therapy. So I think in functional MR, maybe transcatheter has a little bit of edge right now. But I think they go hand in hand. For us, we see it all the time. We necessarily don't go by the patient's age or race, or we go by anatomy, like what will give the patient best possible result. And sometimes it's surgery, sometimes it's transcatheter.
Right. No, I think that's right. So, Amy, I'm going to give you the last word, but I want to ask Joan one quick question. We have 3 minutes left. Joan, what are the implications of COVID for the management of these patients? What have you seen in the TBT registry? One quick answer from you, and then I have one last question for Amy.
I think COVID has, as everything, it's affected some TAVR programs. Some hospitals have considered TAVR an elective procedure, which it is not mostly. And that is where our valve coordinators have really mustered up the strength to lobby for each and every one of their patients under their care in advocating for procedure to go forward. I have story after story after story of valve coordinator calling and saying how they're trying to work magic to get cases done during COVID. The same day discharge, trying to expedite. I've heard stories about how hospitals have had special entryways, special rooms, special isolated secret recovery areas, and then escorting them out of the building. The magic that our physicians and our valve coordinators have done during COVID is really something that a movie should be made out of after this is all done. So it is hit the TAVR nation very hard, but they've prevailed, and I think people have gotten care once they've reached the door of the valve center.
And your psychiatric therapy skills have been honed during COVID. I know a lot of people call you and you give them a lot of great advice. So one quick last question for Amy, and I'll do my closing remarks. Amy, Piedmont Heart Institute and the Marcus Valve Center, now the largest valve program in the state of Georgia, and it's expanding its footprint across the state. What does this mean for patients and the sister institutions, soon to be 18 hospitals in the state of Georgia, in improving patient care? Can you just give us a quick 1 minute summary on that?
Very, very short. I think that this expands access to care for our patients. We're thrilled to have a large footprint across the state. Really, we want to treat every patient so that they can live better, live longer. That emphasis on quality of life. It's really just access to care, and providing people what they need to live their life to its fullest.
Thank you so much. So there are a lot of people to thank. I want to thank Pradeep in India right now, Peter and Amy, who are absolutely, it's just such an honor. I'm humbled to be working with them. And then, of course, Joan. I want to thank all of us, all of you who've been here to listen over the last hour. We encourage you to tune in at 3 o'clock with Mended Hearts. Mended Hearts has been supporting patients for more than 70 years. And I know that Andrea Baer, Executive Director of Mended Hearts and Valve Disease Patients at Mended Heart Network, will be discussing their critical support network and how it shifted over the past 2 years. Last person I want to thank is, of course, Alliance of Aging Research. Lindsay Clark has been instrumental to that. Lindsay, I still haven't, this is sitting on my bookshelf right behind me, and this is something that you guys were able to send to me last year. And what you're doing, the exposure to valve disease is absolutely phenomenal. And all of us who practice in this field really are indebted to you guys for really making this your heart valve disease day. And it'll go in infamy as 2/22/22. So thank you, everybody. Have a great day.